Today we're going to be talking about 3 of the most common neurologic complications that are sometimes seen in people who live with EDS and HSD. And these are upper cervical instability, tethered cord, and a Chiari malformation. We're going to discuss the most common presenting symptoms for these conditions, some things to watch out for that are really red flags that require urgent attention, and the first steps that you can take to try to get care if you suspect that you may have one of these 3 conditions. Hi, I'm Dr. Clair Francomano, and I'm a medical geneticist who's been taking care of patients with EDS and HSD and other hereditary disorders of connective tissue for almost 40 years. This is my YouTube channel where we talk about all things related to EDS and HSD. So, upper cervical instability may include instability at the joint where the head joins up with the neck. We call that the Craniocervical junction. Or it may be instability between C1 and C2, which are the topmost cervical vertebrae in the spine. C1 is the vertebrae that interacts with the skull, and then C1 and C2 have a disc in between them, and they sit right below the skull. So the craniocervical junction between the skull and C1 is probably the largest joint in the body. It's where your bowling ball head sits on your pencil of a neck, and the tendons and ligaments that hold the head in place on the top of the neck are made of the same materials that hold the shoulders and the elbows and the knees and the hips together. So if there is instability at all those other joints, it stands to reason that there could be instability where the head joins up with the neck at the craniocervical junction. Now, the movement that the craniocervical junction controls is flexion and extension of the head. So when you put your chin on your chest like this or look up at the ceiling like this, you're moving at the craniocervical junction. C1-2 is responsible for the rotational movement of the head. So when you're moving from side to side like this, you're moving at C1-2. And C1 and C2 are a little bit unusual in terms of the anatomy of the vertebrae. C2 has a finger that sticks up like this. So there's a little bone that sticks up from C2 that's called the odontoid, and C1 wraps around it like this. And typically, when your head moves from side to side, C1 and C2 are moving together. But if there's instability between C1 and C2, C1 will rotate off of C2, and we see what we call unroofing of the lateral mass of C2, which may happen in either direction. So that's what we're looking for when we do imaging to try to determine whether there's instability at C1-2. So the first thing to think about is whether the symptoms are happening when you're looking up or looking down or looking from side to side. And those symptoms may be dizziness, wooziness, they may be changes in vision. There's a phenomenon that we call the cervical medullary syndrome, which is a constellation of symptoms that cause us to think that there could be instability either at the craniocervical junction or at C1-2. And there are 3 elements to the craniocervical syndrome. They are pain, symptoms related to compression of the brainstem, which is the part of the brain that sits right there at that craniocervical junction, and then symptoms of myelopathy that happen because the nerves that go to the whole body are coming through that opening at the base of the skull, and they're all being impacted by instability. Those nerves are being compressed because the anatomic structures of the skull and the spine are impinging on the nerves as they come out of the brain into the spinal cord and down to the rest of the body. So the pain that's typical of the cervical medullary syndrome is typically headache, There may be suboccipital pain, meaning just at the base of the skull where the skull joins right up with the neck, and there may be neck pain. And often patients will describe this as coat hanger pain, meaning looks like a coat hanger if you describe the distribution. It goes down the neck and then into the shoulders and the muscles in the trapezius muscles and so on. So that combination of headache, suboccipital pain, and neck pain or coat hanger pain is very typical of the cervical medullary syndrome. The second element, the brainstem symptoms, are related to compression of the nerves that we call the cranial nerves. And those cranial nerves, there are 12 of them. They control things like our hearing and our vision, swallowing, our voice. And so the changes that we see with brainstem symptoms are things like blurry vision, double vision. You may see a little bit of movement of the eyes, a wobble in the eyes like this. We call nystagmus. There may be diminished hearing, ringing in the ears or tinnitus, difficulty swallowing or choking, changes in voice. And we also can see problems with the autonomic nervous system because the vagus nerve, which is the nerve that controls the parasympathetic nervous system, is one of those cranial nerves. And if that is being impacted, then the autonomic nervous system will be dysregulated. And we can also see disordered sleep also as a function of the dysautonomia. So those are the brainstem symptoms that we can see. And then the symptoms of what we call the myelopathic symptoms are weakness. There may be clumsiness or changes in gait, and there might be problems even with urinary urgency and frequency because, again, the nerves that control everything are coming through that opening at the base of the skull. Particularly in C1-2 instability or Atlanto-Axial instability, people may also describe really burning pain in the limbs. That's often very typical, and a decreased sensation to pinprick, or decreased sensation to pain in general, although they have this sensation of burning pain. External symptoms or external influences that ordinarily might cause pain might not be detected as easily. That's in general the symptoms that we see with upper cervical instability, which may be either craniocervical instability or Atlanto-Axial instability. And it happens that the same constellation of symptoms is typical for a Chiari malformation because the Chiari malformation happens when the base of the brain is actually protruding through the opening at the base of the skull. So ordinarily, the brain sits all within the skull and it connects with the spinal cord through the opening at the base of the skull, which is called the foramen magnum. And in a Chiari malformation, that base of the brain or the cerebellum actually extends through the opening at the base of the skull. And those cerebellar tonsils, which are the bottommost portion of the cerebellum, can be seen in the place where the cervical spine is really supposed to start. So you have the cerebellum protruding through the opening at the base of the skull or the foramen magnum. And the symptoms for a Chiari malformation are very, very similar to those that we see in Atlanto-Axial instability and Craniocervical instability. One difference is that the headache that's typical of a Chiari malformation is often described as a tussive headache because it gets worse when people cough. So that tussive is spelled P-T-U-S-S-I-V-E, and that's a cough-induced headache. Also, people often describe the headache that they have with a Chiari malformation as being a pressure-type headache. Feels like there's increased pressure in their head, and they will often describe pressure behind the eyes. It feels like the eyeballs are just going to almost pop out. There's so much pressure behind them. And typically, these pressure sensations, the pressure headache and pressure behind the eyes, are very sensitive to changes in the barometric pressure and may become much worse if there are changes in the barometric pressure if a storm is coming in, for example. So those are some additional things in addition to the cervical medullary symptoms that I described earlier to look out for in a Chiari malformation. Now, for a tethered cord, the symptoms are more in the lower part of the spine. The tether of the spinal cord takes place typically in the part of the spine that we call the cauda equina, which is the very bottom part of the spine, the tail of the spine. And there is a band of connective tissue that's found in that location that wraps around the spine, and typically it sits there. We all have this band of connective tissue. It's called the phylum, but for some reason in people with the hereditary disorders of connective tissue, and particularly EDS and HSD, that phylum can become tight and it puts a grip on the bottom part of that spine, which we call the cauda equina. And the nerves in the cauda equina are traveling to the pelvis, to the legs, to the bowel, the lower part of the bowel, to the urinary system, the bladder, and to the pelvis. And so the symptoms that we typically get with a tethered cord are low back pain, because that's where the issue is originating with this tethering and compression of the nerves. But also people may describe heaviness in their legs, difficulty walking upstairs or walking up a hill, which may become more pronounced with additional effort. There may be urinary urgency and urinary frequency, difficulty starting the urinary stream, and sometimes difficulty stopping the urinary stream, maybe incomplete emptying of the bladder. And sometimes people will say it feels like they urinate and then they get up and then it just feels like they have to pee all over again. And urinary incontinence can also be an issue, so some leaking may occur. In the bowel, we see really severe constipation at times because the colon motility is impacted by this compression of the nerves that go to the bowel. And sometimes if the nerves that go to the rectum are impacted, there can be bowel incontinence as well, so some leaking of stool can happen. Often children who have a tethered cord are described as toe walkers, that rather than walking, putting their foot down with their heel first and then going to their toe, they're walking around on their tippy toes, and the parents notice that they're toe walking. And another thing that we see in people who live with a tethered cord is there's this preference for sitting with their feet curled up underneath them. So they'll sit like in a crisscross applesauce kind of position, even if they're sitting in a chair. And sometimes if they're sitting in a car, they'll prefer to put their feet up on the dashboard rather than down on the floor. And, sometimes my patients have told me they'll even drive with one foot up on the dashboard and the other hand on the wheel. So that is typical of people who have a tethered cord, is this preference to be kind of in a more curled up position. They'll tell you that they prefer to sleep in a fetal position with their knees curled up to their chest. So if all of these things or any of these things are true for you and you're thinking that you may have a tethered cord, what can we do about it? So the first thing is to start thinking about looking into, is there evidence of a tethered cord on imaging? Now, for children who have a tethered cord, often that tether is pulling down on the cord, and at the base of the spinal cord, the cord comes to kind of a point that's called a conus, and that conus typically sits around L1, L2. But with a tether in young children, that can pull that conus down to L3, L4, sometimes even L4, L5. So if that's the case in kids, we can make the diagnosis of a tethered cord pretty easily. But as we grow and into adulthood, the phylum, that band of connective tissue that's putting compression on the cauda equina, can stretch out, and it stretches and stretches until the conus winds up back in its original place. It's sitting at L1, L2, just where it belongs, but the nerves in that cauda equina are still being pinched. And so that's a situation that we call an occult tethered cord, which means the cord is tethered, but we can't see it on the MRI. So a couple of ways that we can go about further investigating that are to look for evidence of compression of the nerves that go to the bladder by means of a test that's called urodynamic testing. And urodynamics just tells us whether the nerves that are going to the bladder are responding appropriately to the symptom of the bladder being full. We fill the bladder from the outside, and ask, when do you perceive that bladder is full? And then have the person urinate and can measure the way the bladder responds to that signal of being told to empty. So urodynamic testing is something that can be done, and typically that's done by either a urologist or a urogynecologist. The other option that we have for imaging is to see whether the cord changes position when the person goes from lying on their back to lying on their front. So ordinarily we do an MRI of the lumbar spine with the person lying on their back, and typically the spinal cord will be resting against the back of the spinal column when they're lying down on their back. But when you turn over, the spine will actually drift down and rest on the front of the spine if it is not tethered. But if there is a tether, that may hold it up against the back side of the spinal column. And if we see that it's not moving, the spinal cord itself is not moving when you go from the lying on your back to the lying on your front, or what we call from supine to prone position, then that's another indication that there may be a tether of the spinal cord. I didn't mention how we evaluate for the craniocervical instability and Atlanto-Axial instability and the Chiari malformation. Now, for craniocervical instability and a Chiari malformation, the best test is an upright MRI. In other words, an MRI where we're seated and the magnet is on either side of our head rather than lying down in the big donut that we typically think of when we think of a supine MRI. So the upright MRI helps us because we're able to do flexion and extension of the head easily in that position. So we can do a flexion MRI and an extension MRI and the neutral MRI, and then measure the landmarks at the base of the skull and at the top of the cervical spine and see if there are changes that are typical of craniocervical instability with those movements. The same upright MRI will evaluate for a Chiari malformation because it's looking at the cerebellar tonsils and looking to see whether they protrude through that opening at the base of the skull. And if there is protrusion of the cerebellar tonsils by 5 millimeters or more, the radiologist will call it a Chiari malformation. If it protrudes but it's less than 5 millimeters, then it's called ectopic cerebellar tonsils, or cerebellar tonsils that aren't exactly where they belong. And there can still be significant symptoms associated with an ectopic cerebellar tonsillar situation. So in either case, evaluation by a neurologist who's familiar with Chiari and craniocervical instability is definitely indicated. And for the tethered cord situation, similarly, a neurologist who's familiar with tethered cord and the presentation in people with EDS and HSD is really what you want to go for. For the Atlanto-Axial instability, or C1-2 instability, the imaging of choice is what we call rotational CT scan. This will be done lying down, and then they're going to have you move your head to the left and to the right and look at whether or not there's any of that movement that I described between C1 and C2. The radiologist will look at the angle of rotation between C1 and C2 and whether or not there's any movement that unroofs that lateral mass of C2 when C1 moves off of it. So here again, if you have symptoms, you're suspicious of this, finding a neurologist who's knowledgeable about Atlanto-Axial instability, craniocervical instability, and Chiari malformation is really the first approach. There are a couple of red flags. If any of these things are happening, it becomes a medical emergency. If you have difficulty breathing, if there are symptoms that are suggestive of a stroke with sudden changes in strength or difficulty speaking, or changes in your facial muscles that look like a stroke is appearing, where there's weakness on one side of the face, that becomes then a medical emergency, and it's very important to seek care immediately. 911, and you need urgent help in those situations. So that's kind of a rundown on the most common neurologic conditions that we see in EDS and HSD, the upper cervical instability, Chiari malformation, and tethered cord. If you've liked this video, you may like the one that I've done on pain management in EDS, and you can find that at this link. And I thank you very much for taking the time to be with me this evening. Thank you.